as I shared, very grateful to be here. And as Ravi mentioned, I study infectious disease epidemiology at the University of Michigan, specifically focused on COVID-19. And a lot of my research focuses mostly on disparities. And we also think about how that plays out within the realm of transmission, how people get COVID-19, and also related to the virus. So I thought maybe to begin with, just thought I'd share, like, for the context of this time we have together, that certainly I'm not an expert in any way. There's, in the sense of, maybe there are people within science that have more or less experience. And so, in that sense, I just have a little bit of experience thinking about coronavirus and the different aspects of it. And so really wanted to open this conversation to you all to kind of have with me and share your insights as well from things that you've been reading about and learned about. And then also, I just wanted to share that, within epidemiology, the science of coronavirus and COVID-19 specifically is very, it's a fast moving science. And so things are changing and thinking changes. And so hopefully I could capture some of the thinking that's been happening of late. And then just the last thing, as I shared, I'm an epidemiologist and not a virologist. So I don't study viruses in the sense that at the molecular kind of level, I don't spend time in a lab. I really study how infectious diseases spread throughout a population and how the viruses affect people. And so I just wanted to kind of share that in case, that those aspects will be the focus of the way that I answer most of these questions. So I thought maybe just to begin, I could share that the COVID-19 vaccines that are currently being distributed don't contain a live virus, in the sense that some vaccines that we give children do contain a live virus that causes our bodies to produce an immune response, but the COVID-19 vaccines are not those. They're actually not capable of making us sick with COVID-19. And then the vaccine can also reduce our risk or the severity of our illness, but it cannot eliminate our risk entirely. And so in this way, if someone were to get a vaccine, we can have reduced likelihood of getting sick, or how sick we get if we are to get it. But there's really no way that we know of to completely stop the virus from entering a person. The two currently approved vaccines, the Moderna and the Pfizer, have different degrees of effectiveness, which are both about 95%. And this percentage is really just when they have two groups of people, one that's been given the virus and one that hasn't. One that has been given the COVID-19 vaccine and one that hasn't. It looks at, of those people who got COVID-19 in the two groups, how much did the vaccine provide protection. So I'll talk a little bit about this idea a little bit, but I just thought one of the aspects that's quite interesting about this vaccine is that never in the history of science has there been an mRNA vaccine. And so that has been, I've seen in the media and different accounts that it has been the subject of different, generally not knowing the effects of this type of vaccine. But mRNA vaccines are quite interesting, and this short clip will kind of share a little bit about what they are. And I thought maybe it could just help us clarify as we're thinking about how these vaccines work, why they're one so effective, but also what makes them safe in our decision making around whether to take the vaccine or not. All right, so hopefully everyone can see this and hear this. Okay, so yeah, so I thought, if that was a little bit helpful in kind of determining the different aspects of what makes an mRNA vaccine, particularly the messenger RNA vaccine, so effective. It's really that these, as was shared in the video, these spike proteins kind of mimic the ones that are on the coronavirus cells themselves and provide us protection. And so they're incredibly safe, and that's one of the reasons that make these vaccines so effective as well. Unlike maybe like the flu vaccine, for example, that we take every year, many of us has a level of effectiveness that's closer to between 40 and 50%. And so we're very, it's so wonderful to have these vaccines available to us, and that the science around it has developed for us to be able to use it for COVID-19. The other key element of understanding the safety of vaccines is related to this idea of a randomized control trial that we've seen in the media a lot. These trials, they're called the Moderna trials, the Pfizer trials that we've been hearing about. These trials are what the Federal Drug Administration uses to determine if vaccines and any drug is safe. And so what's really done is there's this population of people, this sample population, and it's like a roll of a dice, and they're randomly put into these two groups. And what that randomization does is it really ensures that there's nothing different between the two groups in terms of like their pre-existing conditions, their age, their other aspects of their health, anything that could affect if the vaccine is going to react negatively to them. Everything except is the same in these two groups. And so when you give one group the vaccine and the other one the placebo, you inject the people in the control group with something that's not the vaccine, just like water or things like that they inject. Then we get to see really any reaction that anyone has. Is it truly due to the vaccine, or is it just kind of happenstance? And so this is an incredibly powerful tool that we have to be able to determine if a vaccine is safe or not, if a drug is safe or not. And these trials are what we're done at, we're done in the correct way for both of these vaccines that are available to us now, which is how we know that they're safe. And so I just wanted to kind of jump into the questions. I thought that maybe those two kind of key aspects of how we determine why these vaccines work and what makes them safe could just help us have a conversation about these next few questions. But again, maybe I can stop here if there's any thoughts or anything that popped into anyone's mind. Great. Okay, so this was a question that someone asked after getting the second dose of the vaccine, is it relatively safe for employees who have gotten it and those they're interacting with to begin working more in person? It's a really great question. I'm sure is on many of our minds. So in general, the Center for Disease Control, our national body that thinks about public health, really maintains that we should have social distancing and all the aspects of it, that including wearing a mask, maintaining at least a 6-foot distance, being in ventilated areas, frequent hand washing, avoiding crowding, that all of those things should be maintained even after getting both doses of the vaccine. This is for a couple of reasons, which I could go into, but it's really one of the things is that, as I shared earlier, these vaccines are not 100% effective, and effectiveness really is measured at the population level, so groups of people. And so how effective a vaccine is going to be in an individual person is very, very, very hard to determine. And so the other reason is that one of the times when we would say, okay, we can stop social distancing now, is something when we reach a point called herd immunity, which you all might have heard in the media as well. And that's something that we had, for example, in the past with other infectious diseases like smallpox and things like this, where enough of the population is immune through the vaccine that you can no longer have outbreaks. So if among the 10 of us, 2 of us had the vaccine, And those two were kind of acting as if, that they were immune. And so they stopped social distancing and all this stuff. One of the 10 of us gets coronavirus. The likelihood of those two individuals still getting COVID-19 is much, much higher because they are being exposed from multiple people to COVID-19 versus if a majority of us, like 9 out of 10 of us, are vaccinated, and that one person who isn't vaccinated gets coronavirus, the likelihood of the rest of us getting sick is very, very low because that one person can't really spread it to anyone else and it won't cause an outbreak. And so that's one of the reasons why we want to kind of reach herd immunity before we can stop all these social distancing measures. And there's not yet enough information as well on the how well COVID-19 vaccines prevent a person from spreading it to another. We know that it can, the 95, around 95% effectiveness for both vaccines are related to how likely a person is to show symptoms of COVID-19 once they get the vaccine. But we don't yet know the effect of getting the vaccine and my ability to spread it to someone else, even if I'm not showing symptoms or things like this. So there needs to be more research done on this. So that's another reason why, we're being asked to maintain these social distancing measures. And again, the choice to begin working in person is certainly a personal one, and risk factors would need to be taken into account. And that's at the individual level, similar to when before we had the vaccines. And I just wanted to make an additional quick point related to this, that both vaccines really require for there to be both 2 doses and then a few weeks after the final dose for it to reach those effectiveness levels that we hear about as 95%. So it takes some time for our body to produce an immune response and produce those, those mimicking spike proteins. So maybe I could just stop here if anyone had any thoughts on this or any insights or.
Really helpful and clear.
Yeah, please feel free to stop in the middle of a slide too if something pops into your mind. Another question that someone asked was, could we discuss proper cleaning and sanitation during our pandemic, and how often this should occur? So in general, a workplace health and safety plan can be really helpful within any workplace, and there are national and state guidance around this. But speaking more generally around cleaning and disinfection, routinely cleaning all high-touch surfaces, such as tables, doorknobs, light switches, countertops, handles, desks, certainly the bathroom, keyboards, faucets, sinks, anything that we're touching often can be routinely cleaned. And we generally, in general, we would want to clean it off with soap and water before disinfecting. And disinfecting is different from using, just kind of cleaning a surface like with some water. Disinfecting, generally, when we say disinfecting, it includes a certain list of chemicals. And we know that coronavirus breaks apart because it has something similar to oil in it. And so when we use soap and water for 20 seconds on our hands, the virus breaks down into little pieces. And so that's pretty incredible that we have that at our disposal to use soap and water. But really and that's really effective for our hands and other surfaces like our hands that, we don't want to put disinfectant on. But when we're talking about surfaces, generally if there's dirt on the surface, we clean it off with soap and water to get the dirt off. And then there's a list of, the Environmental Protection Agency has a list of approved disinfectants. And those are really the only disinfectants that are effective against viruses. And so this list is linked here. But a lot of them are ones that we see in our grocery store, like you know, a lot of times there'll be a label in front that says like, you know, 99.9% effective against the flu virus and norovirus, and it'll say, you know, so we've probably all seen those things. But it also, what's key to using disinfectants on these surfaces that were mentioned here is that the concentration, application method, and contact time are important. So for example, I have a disinfectant that's like Windex brand. And if I spray it on the back, it says it has to remain on the surface for 10 minutes in order for for it to actually be effective. And that's what they've observed in their lab when they tested the disinfectant. So those are the types of things that are helpful to know based on the disinfectant that we use. And also disposable disinfecting wipes can be helpful for like an individual employee who's just kind of like working, and then they touch something that someone else is going to touch, so they wipe it off, you know. The frequency of this disinfecting really depends on use. So as mentioned, if there's a phone that multiple people are going to touch, you know, I touch the phone, I wipe it off, and then I go back to whatever I'm doing. Doorknobs, things like that. It's really hard to like clean it off every time someone touches it, but as you know, the more times different people touch it, the increased risk, of course. So there are certain measures like hospitals take, and it would really depend on how many people are in the building and things like that. But yeah, in general, you know, kind of keeping it down, the lower the number of people that have touched that surface in between disinfecting, the better. Again, so maybe I could just stop there, and if anyone has any thoughts or any like tips that you have found helpful for disinfecting.
One thing I'll share is I feel reassured that we're at Many Roads, we're putting in practice some of these things. So that's good.
Yeah, that is great. It's great to feel confident that those things are happening around us. Another question that was asked was, if you get the shots and there is a new strain, will the old shot be ineffective against the new strain? And should one wait for a new strain vaccine to be developed before getting shots, or can you get another shot on top of the previous one? It's a really good question. And in the period between when I first started putting together some of like the questions and the questions were sent, and now, and we can probably see in our media that the talk of these new strains has really exponentially increased. The two different strains are, you know, very much are spreading. So one interesting thing is that the Moderna vaccine has reported some protection, although reduced, and provided against the new strain. So there were no reductions in the B117 strain, or the one that was originally located in the United Kingdom. So if you have the current vaccine of the Moderna vaccine, and then later I think Pfizer has also come out with this, that if you have either of those vaccines, they provide protection equally for the B117 strain. There was, although, a 6-fold reduction in the B1351 strain, and that one was the one originally located in South Africa. So if someone were to get the vaccine for the Moderna or the Pfizer, and then they were exposed to the B1351 strain, they would be 6 times less protected. And so that's a lot in terms of, you know, it's very, there's losing a lot of protection against that strain. But they are testing the utility of an additional dose. And so what they're trying to do, the Moderna company is trying to do, and I'm sure Pfizer is as well at the time of looking this up but they are looking at what the utility would be of getting 3 doses of the current vaccine. And they're also looking at a specific booster for the B1351. And so it would that one is in phase 1 trials now. So you get the 2 vaccines, be protected against most strains, and then to get have protection against the B1351 strain, you'd get this booster. And that's what they're trying out now. So again, if anyone has any thoughts. Or if anything you saw conflicts with what was shared as well. Sometimes I'll like tell my mom something and then she's like, I heard something different on the news.
Ramya, I think I read, I don't know if my voice is echoing for you guys, but for me it is, that we should basically assume that those strains are out there, and that act as if like basically the things that you just described are true. And I just wondered if you would then that would also apply to the questions of working in person and social distancing and whatnot.
Yeah, absolutely. We know that the B117 strain is has a higher attack rate, and or the amount of people that would get sick from one person is higher for this strain, the B117 that originated, or we think originated in the United Kingdom. And so yes, and we know that, for example, there have been reported cases in my county here in Washtenaw. I'm sure that many counties are testing to see if the strain has, come to your particular place. And yeah, it is a matter of time. I've read things that have said that in the next 5 months that the B117 strain will be the predominant strain of what's found in the United States, just because it is so infectious. And we'll also have the vaccine rollout, so yeah, but it will probably overtake the previous strains. Yes, and then the B1351 strain, I think we know a little bit less about that one, but seems to have other implications. And yes, we should assume that these are out there, and it certainly has implications for social distancing because yeah, it's as if like another virus has arrived. And so we're not at square one. I don't like to think about it that way, but we are, we're in a different place than some other countries that have been able to control the previous strains, because we'll have multiple strains going around.
Just to clarify,
yeah,
I'm hearing echo. I was hearing that there's like a fungus virus that's more powerful than the COVID. Is that what you're referencing?
That's a really good question. I'm not aware of a fungus virus, and I will certainly try to find out. Maybe I could get back to Ravi about it. But the B117 strain is the one that originated in the United Kingdom, the UK, and it what they think happened, and I think this was pretty predictable, is that people with lower kind of immunosuppressed people, the original strains that are circulating right now, when a person that has an autoimmune disease or has a poor immune system, the virus is able to replicate in their body at a rate unlike other people. And it continues to stay in their body for longer because their body is unable to produce the antibodies, say, for example, of someone who gets coronavirus, gets pretty sick, but then they're able to recover. And so in that process, it allows for a lot of mutations to happen to the strain. And so most likely that's what happened with, and then now we have something that is still COVID-19, but it's another it's a mutation of it. And it's more similar to like plants, that kind of the hardier ones survive. And that's maybe what happened here. So this more infectious one is now.
sorry, a quick question about that. So my sister has she has mast cell activation disorder and a couple of other chronic illnesses, and she actually got the coronavirus in March when it first and had pretty severe symptoms, collapsed lungs, and she had COVID to it as well. And she's actually been experiencing a recurrence of symptoms almost monthly. And they're enough she gets a really severe fever, she gets really severe headaches. And this is something that I've actually heard of from a couple of different people who have had the virus, is that they get these recurrent issues, but they're testing negative. Is it possible that they potentially have a different strain, or is this and they've managed to somehow grow that in their bodies, or is it more of a retroactive immune response?
That's a really, really great question. And it's certainly possible that, the virus could have mutated in their bodies. In general, the tests that we have for COVID-19 pick up on all strains. And so, but the tests are also not, there's an idea of false positives and false negatives and things like this. So the tests are not 100% effective either. But the more tests you get, the more confident we might feel about the fact that maybe our bodies have cleared the virus. But I have also heard of, there is something known, which I'm sure your sister, well, first I just want to say that sounds really, really hard. And it must have been so challenging for your sister to go through that. And I think this is one of the most challenging things about this virus, is that it causes long-term impacts that we're still learning about. And one of them is that, the science on it is still pretty nascent, but one of them is that our bodies develop such a strong immune response because we're trying to fight it off, and the virus is so strong that it tends to kind of give our bodies for children, this tends to happen. We'll see children maybe show no symptoms or even recover really quickly, and then a couple of months later have something similar to like a toxic shock syndrome, where they'll spike fevers and they'll have different kind of headaches, and it appears that they're sick again. But it's really the body has kind of put it into high gear and is essentially in shock. And I don't know, there's also sometimes in tampon boxes, there's a little sheet that talks about toxic shock syndrome. It's not indifferent to that. It's not that the body's fighting off a virus, but it's in shock because it has tried to fight off something that it had a lot of trouble fighting off. And so those are all possibilities. And yeah, I have heard, and there's documented cases that the long range effects for people even who are not immunocompromised are pretty well documented. And
Sorry, one more question on that. Would it be possible then in that situation for every time any sort of immune response was needed, whether or not it was for another coronavirus that causes the cold or something else, that your body would then overreact, almost like overcompensating? Is that potentially what could be happening?
that I actually don't know. That's a great question. And I could ask someone who is more on the virology side about that. But yeah, I don't know if the mechanism, if the immune response that one has would kind of be triggered by another type of virus, like a norovirus or something like that. Yeah, that I don't know. It's a really great question.
Thank you so much.
Yeah, and just a quick comment about the long hauler experience. So there's a really helpful report on 60 Minutes. If you go into YouTube and put long haulers 60 Minutes, like it should come up. And one thing I just wanted to also mention is that I'm aware that there's like specialty clinics that have been developed or been coming about in different places because so many people are dealing with repercussions of COVID longer term. Two that I'm aware of in the Midwest are at the Mayo Clinic and in Northwestern. So just as resources, as a, for your family members. And then also Monica had stated in the chat, the fungus infection I heard about that entered nursing homes prior to COVID is called Candida fungal disease. And after COVID is resolved, that will come forward more.
Yeah, that's a really great question. Candida is, it is a fungal infection, and it's a really interesting fungus because most of us have it living on our bodies. And so it's something that affects some people and doesn't affect others. And the amount, of course, matters that someone has. So we naturally have candida in our bodies. And but yeah, I'm not aware of the relationship between candida and coronavirus. That's a great question. I could certainly find out more about that.
So one thing, just a time check, we're at 12:47 and I think we have till 1 o'clock, and I think there's a couple questions left, if I'm remembering correctly. So
yes, I could go through those, and then unless there are any other questions. Another question that was asked was, if you have allergies, should you not get the shot? And what are employers doing to accommodate those that are advised by their doctor to not take the vaccine due to allergic reactions, and what is recommended? It's a really great question. Allergic reactions are an important aspect. So there is an inherent risk or allergic reaction possible for all pharmaceutical drugs. And this risk is assessed using the randomized trials that I shared about earlier. And the Federal Drug Administration runs those randomized trials to also look at the amount of allergic reactions that people have due to the pharmaceutical drug or vaccine. And so that is just kind of one aspect of it. So for example, when our children get their vaccines when they're young, or even when we are going to have an antibiotic, allergic reactions are possible with those, and those are assessed through these trials as well. The 2 approved vaccines in the United States don't contain latex, preservatives, or eggs. That's one of the amazing things about mRNA vaccines, is that you don't have to use those things that some other vaccines contain. And there have been very few cases of allergic reaction to either vaccine when we consider the number of people that are vaccinated to the allergic reaction that actually happens. One thing that has been noted recently in some recent studies is that there is a relationship between, if someone has had an anaphylaxis or allergic reaction before to anything, either another vaccine or they've had an anaphylaxis reaction, which includes hives, it can include difficulty breathing, things like this. If they've had an anaphylactic reaction before, then about half of those people who experienced an anaphylactic and allergic reaction to one of the vaccines had a previous history of reactions. And so that's quite promising in the way that those people have this history, their body reacts a certain way to things. And so this is certainly something to report to your doctor or someone that's helping you make a decision about whether to take the vaccine or not, and should be considered the risks and benefits of taking the vaccine versus having a reaction. No one that has had an allergic reaction to the vaccines that we have documented have had, there has been no mortality reported, and the majority of the people recovered at the time of the report. But I just, wanted to share that those are some of the things that we might consider when we're thinking about that with regard to either of the vaccines. The difference in reactions to either of the vaccines, they're pretty similar. They're so small, the numbers are so small, but for the Moderna, it's a little smaller, 2.5 cases per million doses administered. And in the case of Pfizer, it was 11.1 cases per million administered. So those are the numbers if someone's interested. With regard to this question of what should employers do or what should employees do if they cannot take the vaccine because of an allergic reaction, a fear of an allergic reaction. One thing that might be helpful is that it's interesting, in our country, adult vaccine mandates are very rare. They actually don't occur. At least 16 states require influenza and Hep B, but only if you're in a post-secondary educational setting. And that's the extent to which we have vaccine mandates for adults. And so it's very, very unlikely that the COVID-19 vaccine will become mandatory for anyone. Even, for example, in our healthcare system at the University of Michigan, healthcare workers can opt out of taking the vaccine, and many have. Our son had to get his blood drawn, and I was just kind of curious how many of the phlebotomists had their vaccines and how many refused. And apparently out of like 44 had refused. And so it's, those kinds of settings are high exposure settings, but people still had choices, which is important. Employers and the employee would certainly have to discuss the costs and benefits of this. And then similar to before we had the vaccine, the American Disabilities Act will be helpful in kind of determining some of those accommodations that might need to be made. So I just have some of the references, the numbers that were next to the bullets, in case someone thought I could share this PowerPoint if anyone wanted to kind of look into any of and there are links within as well if you have any questions. Yeah, so if anyone has any thoughts or questions, or I'm happy to.
I did have one additional question, and I know that we are almost out of time. And thank you so much for coming and being with us. This probably isn't something that can fully be addressed today, but I know that for me and probably a couple of the people on the call, I have a lot of clients who would technically fall into that phase 1B, 1C. And with the vaccine kind of rollout, it's been really difficult to kind of keep track of who's on what phase, who's doing what. And the thing that I'm most concerned about for that is, how do we help our clients sign up for these vaccines if they're eligible? And what is the process for that, for getting it for a whole group of people that might need it?
That's a really, really great question. And I think that it's been really hard. The vaccine rollout has been driven by a number of different things. And I can speak to what's been happening in our state. For example, there was a certain timeline set, and the doses didn't arrive or things like that happen. And so unfortunately, from my understanding, it kind of feels piecemeal so far. So it will be challenging to say one way. And I mean, I'm sure all of you working at the center that you work at see piecemeal systems all the time that are kind of like haphazardly put together, and this is certainly one of them, not intentionally, of course, but also we can, when we're talking about people who have less access due to their income levels, or there is a challenge. And so I have read that there are going to be more vaccine clinics in lower income areas being rolled out. And there will be, access will be provided more to those places. But really, yeah, I haven't seen anything that has been more centralized that helps people get the vaccine. And that is a need. And like, for example, the professor that I work with, he's been trying to get a vaccine for his 98-year-old mother-in-law, and he's just constantly like refreshing to like get on the list, and then he gets kicked off and get on the list and kicked off. And so, yeah, nothing that I've seen so far. The only thing that I've seen centralized is CDC has an app that you can put in if you have a reaction to a vaccine. That's one of the few things that I've seen that's centralized that is related to the vaccine, which personally I think that's a little disappointing, but yeah.
I think we may have time for one last question or comment before we close. If anyone wanted to ask. Well, if not, then we can just say on behalf of Maddie Rhodes and the Kansas City area, thank you so much for sharing of your experience and the research that you have familiarized yourself with. And thank you also in advance for allowing us to share this recording with others.
Yes, of course. Thank you all so much for your time, and also your willingness to be in a learning process about these things. It's really so commendable. Yeah, so much of information is just getting thrown around right now, and it's great to have a conversation about it.
And if it becomes protracted, if you'd be open to us inviting you back, maybe sometime in the distant future, we would love that.
Of course, I'm so grateful. Hopefully one day I can actually visit too. Yeah.
All right, wonderful. Well, thank you so much. Take care, everyone. Thanks for joining for this conversation today.